Hemorrhage, simply put, means the escape of blood from a blood vessel, what we commonly call bleeding. In oral surgery, understanding hemorrhage is crucial because blood loss, if not controlled, can become life-threatening. Blood is essential for delivering oxygen and nutrients to tissues, so any significant loss can quickly compromise the body's vital functions. In this video, we'll explore the mechanisms behind bleeding, the types of hemorrhage you might encounter in oral surgery, and how to manage them effectively. We'll also discuss shock, a dangerous condition that can result from severe blood loss, and outline the steps for clinical evaluation and management. Let's start by understanding the basics of hemorrhage. Hemorrhage after oral surgery can arise from local or systemic causes. Most often, postoperative bleeding in healthy patients is due to local factors, such as injury to soft tissues or bone. Osseous bleeding, for example, can originate from nutrient canals in the alveolar bone or from vascular lesions like hemangiomas. Recognizing the source of bleeding is the first step in effective management. Whether the bleeding is from soft tissue or bone, understanding the underlying cause helps guide appropriate intervention and ensures patient safety. Bleeding can be classified based on the type of blood vessel involved: arterial, venous, or capillary. Arterial hemorrhage is characterized by bright red, pulsatile blood that spurts with each heartbeat. Venous hemorrhage, on the other hand, produces a steady, dark-colored flow. Capillary hemorrhage presents as oozing from the area with blood that is bluish bright red. Capillary bleeding is usually mild and can be controlled with simple pressure. Understanding these differences is essential for quickly identifying the source and severity of bleeding during oral surgery. Hemorrhage can also be classified by timing: primary, reactionary, or intermediate, and secondary bleeding. Primary bleeding occurs immediately during injury or surgery. Reactionary bleeding happens within 8 hours after initial bleeding has stopped, often due to clot dislodgement or foreign bodies. Secondary bleeding starts after 24 hours or even days, usually from infection, trauma, or elevated blood pressure. Recognizing when bleeding occurs helps pinpoint the cause and guides the choice of intervention. Bleeding can be internal or external. Internal bleeding is concealed within body cavities, such as intracranial hemorrhage, and may not be immediately visible. External bleeding, like epistaxis, is evident as blood escapes through a wound in the skin or mucosa. In oral surgery, external bleeding is more common and easier to identify, but internal bleeding can be more dangerous due to its hidden nature. Both require prompt recognition and appropriate management. The severity of hemorrhage is often determined by the volume of blood lost. Mild hemorrhage involves up to 500 ml of blood loss, moderate ranges from 500 to 1000 ml, and severe hemorrhage is defined as more than 1000 ml lost. In oral surgery, even moderate blood loss can be significant, especially in smaller or medically compromised patients. Accurate estimation of blood loss is essential for timely intervention and preventing shock. Bleeding can sometimes occur spontaneously, especially in patients with low platelet counts or hereditary bleeding disorders. Additionally, hemorrhage can be acute, massive, and rapid, or chronic, where small amounts of blood are lost over a longer period. Acute hemorrhage is more likely to cause shock and requires immediate attention, while chronic bleeding may go unnoticed until anemia develops. Both types need careful evaluation in the context of oral surgery. Blood loss is also categorized by percentage of total blood volume lost. Class I is up to 15%, Class II is 15-30%, Class III is 30-40%, and Class IV is more than 40%. These classes help guide clinical management, as higher classes are associated with increasing risk of shock and organ failure. In oral surgery, monitoring for signs of significant blood loss is crucial, especially in complex or prolonged procedures. Hemostasis is the body's process for stopping bleeding. It involves 4 key steps. First, the injured vessel constricts to reduce blood flow. Second, platelets adhere to the site and form a plug. Third, the coagulation cascade activates, producing fibrin to strengthen the plug. And finally, the clot retracts and stabilizes. Understanding these steps is essential for both natural and assisted control of bleeding in oral surgery. Primary hemostasis involves the immediate response to vessel injury, where platelets adhere and aggregate to form a temporary plug. Secondary hemostasis is the activation of the coagulation cascade, resulting in the formation of a stable fibrin clot. Both processes are tightly regulated and essential for effective bleeding control. Disruption in either can lead to excessive bleeding or thrombosis. The coagulation cascade is a series of reactions that lead to the formation of a stable blood clot. It involves both intrinsic and extrinsic pathways, which converge on the activation of factor X. The intrinsic pathway is triggered by vessel injury and involves factors VIII, IX, XI, and XII. The extrinsic pathway is initiated by tissue damage and involves tissue factor and factor VII. Both pathways activate factor X, which, with the help of other factors, converts prothrombin to thrombin. Thrombin then converts fibrinogen to fibrin, forming the final clot. Several key coagulation factors play vital roles in the clotting process. These include fibrinogen, prothrombin, tissue factor, calcium, and others. Some factors are vitamin K dependent while others are not. The liver is the primary site for the synthesis of most coagulation factors. Deficiencies or dysfunctions in these factors can lead to bleeding disorders, which are especially important to recognize in oral surgery patients. Evaluating a bleeding patient starts with a thorough history and physical examination. Important questions include any personal or family history of bleeding, previous surgeries, easy bruising, or use of medications that affect clotting. Physical examination should look for signs of liver disease, enlarged lymph nodes, or abnormal skin findings. Laboratory tests supplement the history and help pinpoint the cause of bleeding. 4 basic laboratory tests screen for most hemostatic defects: bleeding time, platelet count, prothrombin time (PT), and partial thromboplastin time (PTT). Bleeding time assesses platelet function, while platelet count measures the number of platelets. PT screens the extrinsic and common coagulation pathways, and PTT screens the intrinsic and common pathways. Abnormal results guide further testing and management. Local hemostasis is achieved using mechanical, thermal, or chemical methods. Mechanical methods include applying pressure using hemostat forceps, sutures, and ligation. Pressure is often the first and most effective step, especially for minor bleeding. Hemostat forceps can clamp bleeding vessels, and sutures or ligatures are used for larger vessels. These techniques are essential tools in the oral surgeon's arsenal. Thermal methods use heat or cold to control bleeding. Cautery and electrosurgery coagulate tissue and seal vessels, while cryosurgery uses extreme cold to cause necrosis of small vessels. Advanced devices like argon beam coagulators, vessel ligating clips, and vessel sealing systems provide efficient and precise control, especially for vessels up to 7 mm in diameter. These methods are especially useful when mechanical techniques are insufficient. Chemical agents, such as astringents, styptics, bone wax, thrombin, and various sponges, assist in local hemostasis. These agents work by promoting clot formation, providing a scaffold for fibrin, or causing vasoconstriction. Some, like adrenaline, must be used with caution in patients with cardiovascular disease. Others, like bone wax, are reserved for bleeding from bone. The choice of agent depends on the bleeding site and patient factors. Systemic agents are used when local measures are insufficient or when there is significant blood loss. These include whole blood transfusions, platelet-rich plasma, fresh frozen plasma, and cryoprecipitate. Each component has specific indications and risks. For example, fresh frozen plasma provides all coagulation factors, while cryoprecipitate is rich in factor VIII and fibrinogen. Proper matching and screening are essential to prevent complications. When local measures fail, major arteries may need to be ligated. This requires precise anatomical knowledge and careful surgical technique. The greater palatine, sublingual, lingual, facial, maxillary, superficial temporal, and external carotid arteries are all potential sources of significant bleeding in oral surgery. Ligation is performed only when absolutely necessary, as these vessels supply critical regions and have extensive collateral circulation. Ligation of major arteries involves specific surgical approaches. For example, the lingual artery is accessed via the submandibular triangle, while the facial artery is ligated near the lower border of the mandible. The external carotid artery can be ligated in the carotid triangle or retromandibular fossa, depending on the source of bleeding. Each approach requires careful dissection to avoid nerve injury and ensure effective control. In summary, effective management of hemorrhage and shock in oral surgery relies on understanding the types and causes of bleeding, the body's natural hemostatic mechanisms, and the range of local and systemic interventions available. Prompt recognition, thorough evaluation, and appropriate use of mechanical, thermal, chemical, and surgical methods are essential for patient safety. Always be prepared for unexpected bleeding, and remember that teamwork and preparation are key to successful outcomes in oral surgery.